Okay, so good evening, everyone present here. I, Dr. Gagandeep Kaur, being the co-host of the day. So I welcome you all to the session, the Global Interdisciplinary Summit 2020. So moving ahead after a power pack session, we are moving on to the next session of the day. We are having Dr. Josh with us. So speaking about him, okay, about Dr. Josh. Doctor receives specialty training in oral surgery, orthodontics, and prosthodontics. He's a board certified implantologist with over 20 years of experience of private practice in the United States. He places and restores all of his own dental implants and has performed over 10,000 implant surgeries and restorations. The only person in the world who has a diplomate certification in both mini dental implants through the International Academy of Mini Dental Implants and multiple diplomate certification in conventional dental implants through the International Congress of Oral Implantology and the International Academy of Dental Implantology, both certified in dental implantology through the ICOI. He received scholarships to attend the University of South Dakota after graduating from Washington High School. He completed his studies in 3 years while finishing the cum laude honors and received a scholarship to attend the University of Minnesota at that time. Doctor began restoring and placing implants in 1997 and continued to be heavily involved in the forefront of implant therapy in the US. He has helped develop 2 independent dental implant lines for manufacturers. So with this, I would like to guide all the participants to follow the registrations as well as see certifications in the description box. We've provided the links there. So with this, I welcome Dr. Josh, and so the stage is all yours.
All right. Thank you very much. I want to thank everybody for having me here today. I'm very excited. And I'm looking forward to getting on with this lecture here today to see what everybody would like to learn. I tend to be a very out-of-the-box thinker, and I'm going to share my screen in just a moment here. We're going to get into the lecture. Okay. Can everybody see everything I can okay?
Yes, so that's perfectly fine. You can proceed.
All right. Excellent. Okay. Well, what I'd like to talk about today is minimally invasive surgery in general, and then extractions and flaps and how they're related, and then also a little bit, of course, how that involves with implantology. So this is a little bit about me, and if you look in the top right corner, you can see my main operatory. One of the things that I find that's very important when my patients come and they can choose many, many practitioners is that they feel confident and comfortable with me. So the operatory that I use for my consultations has all of my award certifications and publications placed on the wall so that they can sit and read it, you know, while they're waiting for me to come in the room. And I think it gives them a sense of ease and comfort. So I highly recommend that you take like your continuing education certificates from this and put them in frames and hang them up so that people can actually tell that you spend the time to learn and do a good job. So moving on here. This meeting, I'm excited to say that I'm going to be speaking at the AOI, and it is now August 22nd and 23rd. So if you'd like to hear me there, and if you'd like to actually to hear something specific, you can message me through Facebook, and I will try and include it in that lecture on that day. So I'm very excited to come to India myself and speak to you directly and meet many of you. So thank you. All right, so minimally invasive surgical procedures are very important for a number of reasons. And one of the things that I think is most important is that we realize that this is nothing new. So if you look in 1931, it was the first attempt to really do a minimally invasive surgery because many surgeries at the time were almost life-threatening because we did not have good blood transfusion equipment, we didn't have good blood typing, we didn't have good anything in medicine. So you could literally die on the table during a surgery because it was invasive and that you couldn't recover from it. So this is an article that talks about the first arthroscope and then the first actually atlas of arthroscopy right here. And you'll see with the arthroscopy that there was an atlas, and then everybody soon became able to start. One of the things that was interesting, though, is when they found that as you tried to become more minimally invasive, you had to learn to do new techniques, and it took time, no matter how skilled the person, to actually learn those techniques. So even if they were very good at the conventional surgery, they might not be at the new minimally invasive surgery. So you will not be faster when you try a newer non-invasive method until you have the proper training and then of course some practice. So it takes time to develop the skills. And if you don't seek out the additional training and try to just use what you already know to do this new technique that you saw a picture of on Facebook, you're likely going to have some failures and not understand why. So I highly recommend that you do try new things, but that you get the training needed before you try them on your actual patients. So it is not a good idea to take everything that you try and incorporate it. Many times when I have personally tried to do something better or different, because I do things many times out of the box, I find that it didn't work better or faster. Maybe it did work better, but not in a clinically significant way, and it wasn't faster, so it didn't benefit myself or the patient. So as a surgeon, we have to figure out what's best for our patients and then guide them. But at the end of the day, they're the ones that actually determine what they want to have done, and we're the ones that get to follow up. So over time, I have found many things that work well and don't work well. I see many young surgeons that have one good result, and they go and they talk about how this is the way to do it. This is how it should always be done. And if it's not done this way, it's wrong. Well, I'm the person to tell you that everything works sometimes and everything fails sometimes. And that it's very important that you spend the time to see what technique works best in your hands, and understand that just because it works best in your hands does not mean that that will be the best technique for another doctor to learn how to do it. Everybody learns differently. Everybody performs procedures differently. So a wise person knows there's something to be learned from everyone. And I think the things that I've learned the most from are my failures. And I really think that if you see a practitioner and they're advertising all, their courses and services and techniques, if they're not willing to show you their failures, then they're really not showing you anything, because you learn more from their failures than you do from their successes. So that's really my focus, is on how I learn from my failures and how I keep trying new techniques, advances, so that I can keep learning and helping others. So why do we want to do anything non-invasive? Non-invasive techniques, of course, are very important to us because we know that we can get better outcomes if it's non-invasive. But why? So the research is already done. The results of the studies have demonstrated that, flapless surgery using minimally invasive techniques are predictable. These are, of course, for implantologists. The benefits of the procedure are less in surgical time, minimal changes in bone loss, probing depth. So essentially, you have a better long-term outcome with implantology if you can do a flapless surgery. But flapless surgery isn't always possible. However, with flapless surgery, you can get a better outcome. In many cases, and we're going to go into this in a little bit, flaps are important for one reason and important not to do for another reason. So at the beginning, of course, we have to check our health history and see where we're at with the patient. The Endocrine Society in the United States met and recently increased the values of vitamin D. Vitamin D is extremely important when we talked about invasive versus non-invasive surgeries because of oxidative stress. Oxidative stress is well known and decreases the amount of vitamin D from surgical procedures. So the longer the procedure, the longer the surgery, and the less vitamin D we have left after the surgery. Many times people will have a weaker contact from the implant to the bone for a few weeks after the surgery. And this in all likelihood could be a big factor with oxidative stress reduction due to low vitamin D due to a more invasive surgery. I can tell you that I do many, many immediate load implants, and that because those are almost always flapless, they tend not to ever loosen up. And I do test them with an ISQ device at the time of surgery, shortly after, and then ongoing, and I'm not seeing these changes. So right now, when we test for vitamin D, if you look here on the screen, we want to have 40 to 60 prior to surgery, and I actually like to double up. For obese people, you're actually going to have 3 times greater than the recommended dose, and that's really important. So all of these are research articles that if you can look at them up later, you can read them at your leisure and see where I'm coming from with these ideas. So vitamin D sufficiency is very important, but the oxidative stress is the main thing that we're concerned about, with surgery. We can't have good bone metabology without vitamin D. Vitamin D is needed to be there for the calcium to be uptaken out of your blood into the bone. Without that, we can't grow good bone. So if we have low vitamin D, we're going to have a bad outcome. So many times I have found patients that when I look on their CAT scan before I start the surgery, I see it has osteopenia or osteoporosis. And when I will ask for the vitamin D test, their level will be below 10. So when it's below 10, unless I can get bicortical stabilization with a light function, I'm going to put them on vitamin D supplements and get that up before I start surgery. So, all right. Let's see here. We have just some other values here. I do like to have my calcium a little bit above. Cholesterol, I like below 200. Of course, I'd like it to be down around 120. For some reason, I have had a number of very thin females with cholesterol levels well above 250 that you would look at and not predict would have that high cholesterol value. You want your calcium to be present. You want your vitamin D so that your calcium is uptaken into the bone. Other than that, this is the dose that I put people on. I have them on a 50,000 unit tab once per week. It's fat soluble, so it's much more likely that they'll take 1 tablet per week than if I put them on a lower dose and have them take it every day, for example. So the less invasive the surgery, the less oxidative stress and the less use of vitamin D. So here are some flaps. A couple of comments. So this is the new chrome guided surgery, and it bolts onto the bone. It requires a very large flap, and of course you make all the bone flat. You can get a very flat ridge with it. I think it's in most cases far too aggressive for what it needs to be. I think if you are trying to change like a gummy smile appearance, change where the position of the teeth are, that's different. Or if you need prosthetic space, that's different. But I think many times practitioners like to do this and go in and flatten the ridge and place these immediate load implants here too deep. They've got the polished collar all the way flush with the bone because that's where they think it goes because these are flush with the bone. This surgery here only had 1 extraction and could have been performed completely flapless if desired. So in my office, I would have done this case without the flattening of the ridge. The tissue looks like it's pretty good all the way around and healthy. So I would have done this particular surgery flapless. I could have punched this, or I would have maybe done what's called a trapdoor flap. The trapdoor flap is basically where you take the letter H and you drop it on top. So you make a little incision here, little incision here. It's about 4 millimeters down on each side and 8 millimeters across. You open a window just enough to make the hole, and then you close the window so that the tissue is laying right back on top. So the only blood supply that's lost is directly over the top of the implant. And I typically will take the bone out from the socket when I drill the hole for the osteotomy and place it on top of the implant. I place my implants a little bit more subcrustal than this, probably a little closer to this side over here, maybe even deeper if it's a conical connection implant. And then I place the bone there before closing it off. And I tend to have really good results with this. So this is a flap that I did myself. And I flapped it because of the different bone widths all the way around, because I knew that I needed to be able to visualize what I was doing all the way through. So there are a number of good reasons to flap, and I'm just going to touch on those. So this is a case that I did with a free gingival graft that I took off the roof of the mouth. And there was no or very minimal keratinized tissue on top of the ridge here. And so what we did is we did what's called the poncho technique, where we use the healing abutments to hold the free gingival graft in place. And if you look, there's a little slit here, 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 and here. And this is an accordion. So what that means is that I made a mistake during surgery and cut my free gingival graft just a little bit smaller than I should have. And so by doing this accordion, I could stretch the actual free gingival graft out to fill my entire defect. So I used one suture here just as a pair of extra hands while I went back and sutured everything up. And so I went through and sutured this in place. So you can see kind of a before, during, and then here's how I closed up the top. At the time, I was working in a remote clinic and I didn't have PRF, but I do like to put PRF here if I can to aid in the wound healing. But whenever you're going to do ridge expansion, you're going to have some flap so that you can expand that tissue out. So here is a vestibuloplasty. This was done because I had been told that you could not do or grow keratinized tissue solely with PRF. So this was a large cyst that was removed here at the time of surgery. That was cleaned out, corrected, and then the vestibuloplasty was brought down to grow more keratinized tissue. The only thing I placed on top of this was PRF, and you can see this is during healing. It's starting to fill in. And then here you can see I've completely widened the ridge with keratinized tissue all the way around, as well as getting my vestibuloplasty. The trick to growing keratinized tissue with PRF only is that you must have the keratinized tissue on either side of the defect so that the keratinized tissue is growing towards keratinized tissue and those cellular markers are going to push towards each other. If I were to cut this on the line of the mucosa, that would not happen because I would have mucosa on this side and keratinized tissue here. So it's very important if you're going to use PRF only to grow keratinized tissue that you keep the incisions within the keratinized tissue before you move them apart. So all right, so here is some ridge expansion. And if you look down here on this photo, you can see that I've used sticky bone. And I've also left this open to heal by secondary intention using PRF only. And these were the results. You can see it completely filled in again with keratinized tissue. And we were able to widen the ridge a fair amount, as well as getting a lot more bony support. This, if you look, the ridge was just under 2 millimeters wide. And so these narrow diameter implants were used at the time and placed in here with some additional bone on mostly the buccal. Rarely do we get any recession on the lingual, so I focus most of my grafting on the buccal, but I do actually add some in here, especially when I have a little defect like this, so that I can get a more uniform shape and size, so that if in the future I get recession and I had to replace this implant, I could have a new location for the lingual. Okay, so this is traditional, guided bone regeneration. So we have a very narrow ridge. And in this case, it was a much bigger case where this patient was heavy bruxer and the bite force would have been too great to place a narrower diameter implant in here. So sticky bone was done. Sometimes you can use tenting poles, you can use tacks, you can use any number of different things. But we do internal mattress suturing here to hold the Teflon membrane in place before we come back and close over the top of it. So this is just normal periodontal surgery, nothing special here, but of course you have to flap if you're going to increase that and to gain height and width. So this is another reason to flap. This is another surgery I performed. This is basically gummy smile correction, where we're taking out an ellipse of the tissue. And you can see this is at the day of surgery. And this is about a year later. And so this is the day of surgery and a year later. It's really important to tie down the muscles in these surgeries. Otherwise, you tend to get a lot of relapse. And this suturing, if you look at it, was all done internally. And that's important. Now, because it's in the mucosa, you're going to have a fair amount of scarring, but that's expected because that's where you need to remove that extra tissue. So. All right, so I'm not going to go into all the oral surgery procedures because it could just go on and on forever. But this is an example of a flap where you have to extend it in both directions to get to the entire defect. This, of course, looks fairly small when you start, and when you open it up and you start cleaning it out, you can see that it just extends multiple areas, both in vertically, horizontally. And so those flaps at that time need to be pretty big and invasive. But if you have good closure and, I again use PRF and sticky bone in this case to complete it, this is what you can get when all is said and done and it's healed up. So in any case, big flaps are fine, but I would tell you that you want to use the least invasive flap that you can every time. So, all right. Reason number 7, this is where I took out a molar, and you can see I removed the roots individually, and I used the septum with densiburs to gradually widen that hole out before I placed the implant in the septum. Now here you can see that these pieces of tissue are still attached to the bone, and I needed to close that tissue. One of the things that I don't like when you have to do this technique is that you do tend to lose some keratinized tissue here. So I always do tell the patient that I may have to come back and do a free gingival graft later. In this case, I relieved both the lingual wall and the buccal wall so that I could bring these together to get primary closure. Why did I do that instead of using a Teflon membrane? I have a certain subset of patients that I just don't trust in my area, where I think that no matter what I tell them, they're going to misbehave and abuse this area. And so when I have those patients come in and I don't think they're going to respect, the work that I've done and the, Teflon that I've put in to protect it, I go ahead and just get primary closure and tell them that they're likely going to need an additional surgery in the future, but that this is more protective than the membrane. Sometimes I have to do this because they simply can't afford to have a membrane placed as well. So in many cases, we have to look at things that are imperfect, but that need to be done at the time of surgery. So, okay. So why do we not want to flap? If you look here, the most important thing is that the periosteum contains osteogenic cells that regulate the shape of the bone. So if we pull the periosteum off of the bone, we destroy that regulation of osteogenic growth. So in short terms, what that means is that every time we create a flap, we stop bone growing there and we cause bone loss to happen there. Now, what's interesting is at the beginning of last year, we discovered an entirely new system of blood vessels that had never been found before. And these go right through the periosteum and go into the bone. So this is coming from the periosteum and into the bone. And you can see this is the blood supply that the bone gets from the periosteum. So if you take the periosteum off of the bone, you've now destroyed the bone's blood supply, again, weakening the implant or bone growth or whatever kind of surgery it is, but you inhibit its ability to heal properly. So this further emphasizes the importance of non-invasive surgery and not taking the periosteum off of the bone. All right, so I am at the point in the United States where we consider, due to my age, that I am going to get a colonoscopy. So I am considering whether I want this to be going and looking in my colon or this to be going and looking in my colon. And I think it's important that the doctor offer all the options. This is the big flap, this is the little flap, of course, and as long as either one will work, I know that I want this one for obvious reasons. So you must always give your patients the option. You cannot have them come in and you just have one tool and you tell them, this is what I do, we're going to make this great, and that's how it is. You need to be a better practitioner and offer them all the options. And if you can't perform the one they choose, you really need to refer them to someone who can, or go and learn it yourself and ask them to be your first patient so that they know that they're giving you a learning opportunity. Okay, so moving on into the atraumatic extraction. So a lot of my patients live very rurally and they don't come to the dentist very often. So they'll come in and most of their teeth are decayed like this. And we call this a terminal dentition. It's not that these teeth couldn't be fixed or that the patient wouldn't want them fixed. It's that they're not going to come back to the dentist probably for another 5 to 10 years. Their habits are not going to change. And if we did spend all the money that they likely don't have, they're likely going to come back with more pain and sooner than later. So at this time, we try to take these teeth out as well as we can and do a minimally invasive job so that they have good healing and minimal bone loss so that this ridge will last a lifetime if possible. Okay, so this is what I like to see after an atraumatic extraction. I like to see the tissue barely look like it's been moved, and I like to see very minimal bleeding. That means that we did get some bleeding from the tooth coming out, but we didn't cause additional trauma, and you can see we don't have big holes all over. So this is a molar that I removed, exactly like the case I did before where I sectioned it and took the roots out individually. Then I placed a maxi plant, which was a 9 by 7 millimeter implant in this area because the patient has a high bite force, but I used a custom emergence profile. And I think those are becoming much more popular. And I think in the aesthetic zone in particular, where you want no tissue to move, they're going to be more and more important. So this is over a period of years. Of course, we're into 2020 now, but I wanted to show you that the shape and the tissue looks the same over a period of years. And I think a lot of that's due to not raising that flap. If I would have raised the flap and closed it like I had in the case with the Densibur, then I do believe that I would have lost some of my keratinized tissue, and I do believe that this ridge would look very different. But by using a larger implant and a custom emergence profile at the same time, I believe that you can get some really nice results like this. Okay, so this is a recent case, and this is an area where do I flap, do I not flap? In this case, you know, of course, you have to flap enough to see, but not more than that. So when do you remove bone? When do you section? So this was not visible on a Panrex, but we were looking at doing an implant somewhere else, and I saw this. And this is actually what's called a paramolar. It looks like a little J here, and it was attached exactly like that to this wisdom tooth up here behind it. So there was a lot of decay on this tooth, and I knew that when I went in, it would be very easy for me to lose something into the sinus here, or to potentially lose this somewhere back in this bone or in the tissue because it was so tiny. So in this case, I did section and remove the mesial portion of the tooth so that I could bring this into the visible area. And then this actually did detach at the time I do that, but it stuck itself out so that I could go in and remove it separately. When I am down near the nerve, as I was here, and I have these turns, I know that with a simple forceps extraction, this is not going to come out. It's simply going to break. So what I like to do is section as low as I can to get to the pulpal floor horizontally. And then once I see the pulpal floor, I can usually see exactly halfway between each of the pulp horns here. And then I can make a nice clean section. I make a section here, and then I just loosen them from the sides to go in there. Of course, you always want to do the mesial root first, so that it's going to rotate around this axis, and then you can detach this from the distal wall and push it into the mesial space. But this is when I like to section, when I'm near vital structures or when I'd have to remove so much bone that it would be harmful to the patient. Okay, so let's talk a little bit about this. As the presenter stated, I am also trained in orthodontics, and when I'm thinking about these atraumatic extractions, I'm always focused on what we call the center of resistance. And that is right here. So it's essentially halfway down the tooth. What that means is that when I push on this part of the tooth here, the tooth will bodily move. If I push on it here, it'll rotate around the axis instead. So where I put my elevator is very important. The lower I can get the elevator, the more likely this tooth is going to come out atraumatically without any issues at all, and quite easily. These represent the force multipliers of each of these teeth. And what I do is I'm constantly adding these up in my head as I do this to push on, let's say I add 3.5 and 4. So this tooth is weaker than this tooth. So I can use this tooth and push this one backward, and it will move because I also have 4 plus 2 plus 2. If I go to this tooth and this tooth, you see they're pretty similar, but you see if I add these two are pretty similar. So if I want to loosen this tooth, I could put my elevator in here and loosen this tooth by pushing these two back. So each time I'm going around the arch, I'm sitting and doing the math in my head. Which one am I going to push on in which direction to make these things loose? So one of the important aspects is that I open the papilla here so that I can get access to the interseptal bone. And then I do that is so that I can get my elevator down to the center of resistance. The way I do that is I take a surgical straight burr, 957, 557, whatever burr that you would like that's a straight fissure burr that's a crosscut. And I remove this little triangular piece of bone here. I do that for a couple reasons. When the surgery is over, all of these little spicules of bone will be taller than the rest of the tissue, and they will slowly fall apart over time. So I've done about 2 dentures a week until recently for the entire time of my practice. And the majority of those, of course, are with extractions at the same time. So I've removed many, many teeth, and I've seen the results with dentures for many, many years. By removing this piece of bone, that is the bone that tends to remodel the most initially and cause the most pain to the patient with little bony spicules coming out. So I take the burr and I remove that down until I get to the center of resistance somewhere in here. Then I'm going to use my elevator down here versus up here. When I go up here is when I tend to break the crowns off in either direction or chip them or pop crowns off. And so that's really important. And it has a secondary function of doing a pre-alveoloplasty for the patient's comfort. I do have a live video that I'm going to bring up, so we're going to be able to see that shortly. Here we go. So you're going to get to see this start to finish. And I'm going to step away for a minute and let you watch this.
Extraction with an immediate denture placement.
Hopefully the sound is good.
If you look at our X-ray here, I'm going to tilt the screen for you so you can see. It's most of the upper teeth. And at this time, we're not going to be doing some implants, but we know that that would improve the situation greatly for the fit and feel, and she's aware of that. But for today's purposes, I'm just going to show how I remove the teeth and how I see the denture. So let me get started for you. Let's keep that out for now. I like to put that in just before I actually am going to remove the teeth. So I use a surgical length 957 burr, my high-speed handpiece, and I take out the interproximal bone areas so that they don't show up as sharp little pieces that are going to come out over time in the tissue. And it does a little bit of an alveoloplasty for me at the same time, which is really nice for the patient. Okay, so we've tested it once for numbness. Go ahead and open. And we're going to do so again. Doing okay. Nothing ever feels great when you have.
Sorry about that. I wanted to stop back and just start here a little bit and tell you the tools. I tend to use a 301 elevator, a Molt number 9, and a Minnesota retractor. So I wanted to go into that. And then the handpiece that I use is an electric handpiece, and I have a number of different oral surgery attachments. I'm just going to use the off-angled 90-degree typical one today. So there's no air coming out of the handpiece because it is electric.
And today I'm going to show you a full mouth extraction with an immediate denture placement. If you look at our X-ray here, I'm going to tilt the screen for you so you can see. It's most of the upper teeth. And at this time, we're not going to be doing some implants, but we know that that would improve the situation greatly for the fit and feel, and she's aware of that. But for today's purposes, I'm just going to show how I remove the teeth and how I see the denture. So let me get started for you. We'll keep that out for now. I like to put that in just before I actually am going to remove the teeth. Okay. So I use a surgical length 957 burr, my high-speed handpiece, and I take out the interproximal bone areas so that they don't show up as sharp little pieces that are going to come out over time in the tissue. And it does a little bit of an alveoloplasty for me at the same time, which is really nice for the patient. So, okay, so we've tested her once for numbness. Go ahead and open. And we're going to do so again. Doing okay. Nothing ever feels great when you have a bunch of teeth that are not feeling awesome, but we've kind of gotten them as numb as we can. So what I'm going to do is go ahead and take away a little bit of bone around these. You can zoom in here. I do a little bit of interproximal buckle on the freestanding one. On the ones where they keep next to each other, I just go in and take off the little ridge. And going down. I want to make sure I get below the center of resistance. So that's more than halfway down the root. Turn the left for me there. Good job. So once I've gotten the alveoloplasty done, I made a spot for my elevator to go. Go ahead and turn your look. And then Kyle, I'm going to ask you to move a little farther out of the way so that Taylor can go ahead and get in a little bit. Go ahead and move this way for me. Thanks. Okay. So now that I've done that.
So there I've gone in and removed that extra bone.
That I can preserve for sewing or anything. I'm just going to go ahead and slightly make sure those are not attached. If they're attached, Then when I remove the tooth, sometimes I'll get some of the tissue, and I don't want to do that.
We do these videos during the day just like any other patient, so that's why you see the video quality is what it is. It's just the best we can do at the time.
1 millimeter in either direction. Once I have that, good job. A little bit of infection in that area. We have used buffered anesthetic, so we know we've done everything possible. Besides double the normal dose of anesthetic, which we're going to do like a restoration. You doing okay?
Yeah.
Okay, good. I know I've tried to get you as numb as I possibly can. So,
Sometimes I believe the patients are mentally prepared to make noises, even though they say they're totally fine and comfortable. So I do always double check that.
okay, I'm just going to put that in right here. Hold that right there for me.
So I've gotten all the teeth to move at least 1 millimeter and hopefully 2 with a luxator.
Good job.
You can see that
Nice and easy.
it starts to come out a little bit easier now that I've removed the bone and luxated it.
Check this. It's not quite loose, so it'll just come out that quickly. And I'm going to come back and push.
So there are the lateral and the canine to push against.
Get it down far enough. That one.
Using those 2 in the back to get the lateral out.
And the canine, let's see, this is loose, so I'm just going to take that out. And the canine, I'm going to grab mesodistal and rotate. Same rotation, always rotate. Good job. Same thing. Ah! There you go. Good job. Same thing. Good job. And I'm going to go ahead and do a little elevation here on the left. Go ahead and turn to your left for me there. Trying to loosen it up a little bit. Good job.
You can see the canine doesn't want to move.
Really infected, so I apologize. Okay, go ahead and put that back in.
There are some apical abscesses as well. With the buffered anesthetic, that does help quite a bit. We use an 8.4% sodium bicarbonate. Of course, I do know that the first premolar has 2 roots, so I'm always a little more careful on rotation when I get to that. And same thing on the other side, that one broke.
I'm going to go back to the elevator just to see if I can get down low enough to elevate just the root, because I've got the canine still to work with.
Remember, the canine is harder to move than the premolar. And there it is. I just got it down low enough that I could do that, even though you could see that when I tried it with a little bit of looseness with the forceps, that it simply just broke the tooth off more.
Now I can get on that mesodistal of the canine again.
Yeah, when you tend to grab the buccal lingual of the canine, it tends to slip a lot. But I think the mesodistal is quite nice. So if you get in there with the forceps on the mesodistal and rotate, I think you're going to have a lot better result. You can see the root was very long and very narrow on that canine. Those are the kind that tend to break off over time.
One more to go. Same thing, just going to go straight buckle. And I'm going to take this out. In this case, I know I have that root tip over here. Go ahead and suction in where I'm looking. And then push that saw back. Get much better healing if you don't.
So you can see I'm not raising a flap unless I have to, because I know that I'm going to maintain my blood supply and make it heal. So I needed to look to see where the root was remaining. And so I'm going in and removing the bone circumferentially around that so that I can get down to the center of resistance of what's remaining of the tooth. And the palatal bone, as I mentioned there, is very firm, so it's a great way to actually elevate off the palatal bone because there's not a lot of interseptal bone remaining, and the buccal bone is going to be too soft to try and elevate. So I can use this the enhanced cortical bone on the adjacent socket here and push against that to take that out as well. So that, arch extraction looks like it took about 7.5 minutes or so. So in general, if it's taking you more than about a minute to take out a tooth, you're probably should improve your
inclusions there.
technique and
We're a
work
little
with
light
somebody
up
who
here.
takes
I
out a
think
lot
they
of
thought I was
teeth
gonna
to help.
take away a little bit more.
Okay.
So we're gonna go ahead and realign this now that we're
I'm
done.
gonna move on
Thank you
because we're
very
not
much.
talking about dentures
Hope that was
today.
helpful.
All right. So this is an example of someone who has one tool in their toolbox. You can see they used large diameter implants and did 2 implants for 4 teeth instead of actually trying to get some training to do an implant that would be encased within the bone upon placement. This seems to be working okay right now, so I'm not going to say it wouldn't work, but I do think that having bone around the implant is better if you can get it. Okay, so I'm going to talk about some different kinds of implants quickly. And if you look here, and please moderator, let me know when I'm out of time. I've got lots of videos we can watch if we need to, but this is a needle implant here, and this is a pure titanium. They're bendable. They've been around for a long time. This particular case is 24 years, and it shows a very different way than, you know, the Brandemark style implants that are very popular today. This is a current study, 2018, and it shows a 97.1% success rate with needle implants. And many people would say that this is not hygienic, it doesn't work. But clearly, if you look at the longevity, 96 to 2012, over all these implants, they do work quite well. Here's the article if people want to read that. All of these techniques work well in the right situations and in the right hands. All of them would fail in the wrong situation in the wrong hands. So just bear that in mind. I think it's really important to think all the time, what's the right thing? What's the right technique? I personally have 18 different surgical kits and use 8 surgical systems all the time. And I still think there's always a situation where I'd like to change something. This is Dr. Tremonti out of Italy. This case, same thing, 1996, 2013, still going well. These are also pure titanium, and they are bent and then welded in place in the mouth, as you can tell from here. So this is a follow-up. Many people say that the ridge lap pontic is not cleansable. Clearly, you can see that it causes no harm whatsoever, and it also creates a nice tissue profile that looks really good. So these patients are very happy. Do not believe that only the Brandemark style implant is successful or works in longevity. That is just not true. They do work very well, though. Okay, here's another one. This is a colleague of mine, Mr. John Blythe in London, who did this case with Replicate, which is a titanium that is milled to match the CAT scan of the root that was removed. And then it has a zirconium crown on top. So the zirconium is bonded to the titanium, and these cases are done with the CAT scan. This is Bioplant. It's been around a long time. And these also, you can see from the molar root here, are done with a CT scan. So the CT is taken and the zirconium is milled to the shape of the tooth with the crown prep involved, and those are tapped into place firmly. These little projections are made to stick off so that it gets really good cortical plate contact. You can see those here and here. And these cases have also been around a long time. To me, this would be the ultimate in non-invasive surgery if it was more popular and more affordable, I guess. All right, this is Dr. Victor Sendax. He passed away this last year. He was the inventor of the mini dental implant. And you can see this case went over 20 years very well. And that in the meantime, someone came back and placed some larger diameter implants on the opposing arch. But this is an example when we were using blades and needle implants. So this is a case that I did with a patient with an obturator. They had a couple of teeth, and these were made as a conical connection so that held on the obturator with friction. And when the patient lost this tooth, there was very little bone, of course, because this was a cleft palate case. And so there was just enough to place some mini implants. And this patient wore this for about 10 years until she passed away. So this is another case where I would be very concerned if I was flapping because of the vital structures in the floor of the mouth, as well as the health of the patient overall. So many times I can take a case that someone else can't do with a more invasive surgery because I'm going to do this flapless and I'm going to do this with some small implants. So in this case, this was about 10 millimeters tall from the very top to the very bottom. And then it dropped down to about 6 and 8 back in here. So this is the only place I felt comfortable getting some implants because the nerve was on top of the ridge all the way up to this point. but I think that the patient had a very good result in her quality of life. Was it a very tight denture? I don't think so, but considering what she had to what she is now, she's very pleased. And another way that we're talking about, everybody's moving to surgical guides. I have a guide system that I created for these narrow implants for narrow bone that you can place the implant, lingual tube, buccal tube, anywhere around the nerve. It's extremely accurate. And these cases, this one was actually placed into the septum in the sinus. So you can engage any amount of bone that you can find. I think it's important to consider these options versus going in and doing a large surgery where you're going to, add a lot of bone here. Many of my patients just couldn't afford that and would have to say no to the surgery in general. This is a case by a periodontal prosthodontist, Marianne Morelli in New York City, and she used the guide system and did this in case flapless. And of course, these are implants that completely fill the bone. So it would be nice if you could do something different, but many people would ask, well, why so many implants? Well, this is a prosthodontist doing this case and a periodontist. She's got both diplomas, and she considers this a good option for a number of reasons, many of them related to health, finances, non-invasiveness, what the patient can tolerate. And when you look at what you can get for results, it's quite amazing. So if you go to the gmdia.dental website, I'm the president of this organization. You can go to this page and there are 7 pages of peer-reviewed articles on why these small diameter implants work well long-term and as good as the normal size implants of other types. Maybe not as good as the needle implants. I don't think anybody else has a 97.1% success rate. So I'm going to let you watch this little video here about one of my patients that I did this case on a number of years ago.
Want me to say what I just said? My implants are wonderful. They feel like a part of me, and I just don't want anything to go wrong with them.
Well, I thought it was so special what you said about Don, that it's the best thing he's ever given you.
Yeah, it's the best thing he ever bought me.
Oh.
He bought me a diamond ring, but these teeth mean more to me.
So you like my gift to you better than his gift?
Well, you put them in and
That's
he
true.
bought them.
That's true.
Yeah.
That's right. Well, Lillian, it's amazing to hear that. Thank you so much.
You did a wonderful job. Like I told her, I can chop a carrot off.
Well,
I take a little carrot and I just cut it in half in my teeth.
it's my honor, Lillian. Thank you so much.
You're welcome.
Thank you.
You did a good job.
I really appreciate hearing that.
Yeah.
Some of these patients like Lillian have a tremendous quality of life change and they're just so happy. So if you look at a surgery that I can perform in roughly 10 minutes for her, including adding that to the denture, the quality of life change, the minimal cost of the implants themselves, I don't need to do a bigger, more invasive surgery if this is as happy as she needs to be. I could, but it's about what does my patient want from me? What can they afford to do? And what will their health allow? So, okay. So if you look at this case, I placed these 10 implants in about, well, it took me a little less than 6.5 minutes. It was done flaplessly. And these are the cases that they look like once they're in. This is the YouTube link if you want to go see that video. And I'm just going to keep going until I'm told to stop. So. All right, so if you look here, this is where we're at now with dentures. You can hear the loud
There's
snap.
the implants. Then this is our trial, so to speak. It's in PMMA. And then if this works out great, we go to zirconia. That is how we do a denture replaced by a fixed removable hybrid with minis.
So I like these hybrids that are fixed but still removable for cleansing because many of my patients get macular degeneration. They can't tell if their implants are clean. They can't clean themselves very well. And right now, if they're screw retained, they really just don't come in hardly ever. Like once every 3 years, these get removed. Now I can get it out. My hygienist can get it out. If their hand strength is still good, they can get it out. This again is done in PMMA. And that is something that we can grind on, you know, do whatever we want to change it. We have our own laboratory that we do work for other dentists, and then we can convert this just with a click of a button to zirconium. If you look over here, this white material is Trilor. So when PMMA is insufficient in strength due to the bite force, we start to use Trilor.
So this is a new type of material called Trilor, and it's supposed to be a lot stiffer. We'd broken the previous one of these, so this is going to get picked up over housings. So if you look at it, you can see this is our design from last time. The patient was happy with it, except for that he kept breaking it. So hopefully this bar material that's on the inside is going to make it a lot stiffer and harder. And this is probably going to be the new technique for these if it works out well.
And I can tell you that so far I have yet to break one of these, and I've put in quite a bit. It's a carbon fiber. At 3 millimeters, I can't physically break it with my hands no matter how hard I push. So I'm hopeful that these will just continue to wear. So these are basically denture teeth on the outside, and then there's Trilor on the inside. And when you take this off of the roof of the mouth, the patients are very appreciative of the taste and the speech changes that they get. So if they can stay in this, then I let them stay in this. If they really feel, you know, they need the additional cosmetics of the porcelain and the weight, then we go ahead and do that as well. All right, so I don't have a lot of extra things. I do have 2 more videos of surgeries for different arches if people want to see them. Otherwise, I'm happy to end it there and take some questions.
So actually, you can go ahead with those videos because the lecture has been quite interesting. So you can go ahead with one of your videos if you wish to.
Perfect. The next patient was actually a little bit more traumatic. And let's see, this one is just under 9 minutes for the lower arch. So it's how I deal with more of my anxious patients. This was during a live surgery course in my office where I had about 20 doctors present. So if you look, you can see them standing around the chair. Sometimes I have a doctor's assist during the live surgery courses, and other times my assistants get to do it. So, but the surgery will be the same. I'm going to step away for this part, and I'll be back.
I want to cycle it all when you will. No, it's not. Here's about the place. Is that first going to be no. Good job. All right, so now I'm going to go turn towards me a little bit. Perfect. And you're going to feel this. It's going to be a heavy, heavy push, okay? Good job. Yeah. Good job. Wonderful job. So you've done this before.
Great job, Gummy.
So here's a little thing. I just put the elevator a little farther and twist at an angle, and then you need some upward movement as well. So I'm going to go through here and do over here for me, please. Whenever I have a piece come off on the top, I just let it in. Come back down a little bit lower. Now that I can reach. Using all the front pieces, thank you. Buckle. You're doing great. I think the ankle is because it was farthest back. The ankle is because I was taking a little bit of bone. So lots of restoration. Yeah, really thin buckle plate. And if you're a fan of it, sometimes there's not a lot you can do. Trying. If it does break through, you want to leave it under the tissue because it's basically a perfect bone graft. Already in the location where you want it. It's already got blood supply. Many times it'll reattach. Now this is a good one because this scoop behind, and you can see that these lips broken off about halfway down. And now you come back in. And I'm going to put the elevator in between these two lips.
Good job, fine.
You break there, you let me know. How you doing? You doing okay?
So if you watch, I basically use very few instruments. I use the same burr for every case and the same 3 tools. And sometimes, you know, if they're parallelly involved, then I won't use a forceps at all. In most cases, I'm going to be using the elevator as apical as I can get it for each tooth. And I just keep going. If they're ankylosed and they break, then I just keep going down and removing more bone, always circumferentially.
Again, the little tiger bone, I'll leave them there. Down on up. And grab the foot. And then I'm going to squeeze the plate back and close it just like that.
So there what I'm doing is taking my fingers on the buccal lingual and just crushing the plate so that I have primary closure around everything. So the bone does tend to get expanded, hopefully mostly mesiodistally, as you can tell when I'm doing that. Sometimes on these narrow-rooted teeth, I use the molt number 9 to extract them instead of the 301 elevator. The tip of the elevator is 3 millimeters, and it's serrated if you don't have that particular number. What I also like is that with the 557, if you cut a semicircle in the tooth, you can actually place the elevator directly in and it will engage just like a screw in a socket. And you can literally pull the teeth out just by doing a purchase point because the burr is lined up with the same size of the tooth. So you can tell we've got some nice doctors there holding the patient's hand. She's nervous, but she seems to be doing quite well.
If you remember earlier, I said that if you can come in from the side, you can get a better purchase. It's a little wider. A little bit of fluctuation on there.
And a lot of times we get these broken teeth that have a lot of root canals and they just tend to break and break and break. So this is a good video to get to watch to see how we deal with those. Again, I'm trying to preserve the buccal plate, so I'm going to remove bone on the distal, the mesial, and the lingual, but not the buccal. And I have the Cometa Bio machine that will allow me to take these teeth and go green, as Dr. Mazur says, and go ahead and grind those up and reuse them as bone graft. What I've discovered is that it does provide a volumizer. I have not seen the enamel rods actually dissolve very well, but I have seen the remainder of the tooth dissolve and integrate into the bone, but it's very, very slow, almost like a bovine, where it takes a lot longer for the bone to infiltrate in between the dentin and the enamel. So I would say that if you want a long-term volumetric graft, then grinding up these teeth works quite well. So, and as far as the cost to the patient, I believe each of the little grinders that you have to have for the machine cost about $60. And so for your cost of $60, you can create an enormous amount of bone graft and go back for these patients and use it. So I do like the system, and I know that Dr. Mazur has a course that he's going to be doing very soon on it, or even it might be a free webinar. So anyway, I think that's another thing. I'm going to go ahead and go to the next video if we have time. If we don't, then just go ahead and interrupt me. And I'm going to go. And here is an upper.
I thought that anticipation that.
You're doing so good. Good job. Squeeze their hands.
Good.
So what I'm doing here is taking away the bone.
We're actually have an emergency patient here for my partner in the practice right now, so I'm going to go and let her know that she can bring that patient. So you may hear some patient noises within the office in the background. As you can see down here, these are many of the surgical kits that I have for doing dental implants. And I'm going to let you watch this for a moment. I'll be right back.
And then also that I can get that element really well. Yeah, now you're holding so now you're in the pocket. Just in the pocket. If you think about it, all of this, all of this has to remodel for that skin to look flat. So it's really helpful to do it in that angle. Okay, I'm going to make a big push. I'm not actually going to take, okay. Let me get the dollar open for me. Open on up for me there. Good job.
This gold elevator, I buy them from a company called Practicon. They're called Easy Outs. And I just like the color because they show me the width. So this is about 4 millimeters at the tip. This is 3. There you go. So you can tell this is a really anxious patient.
Are you okay?
This is some calcium sulfate bone graft that I use at times.
Yeah. Well done.
And again, sometimes I think that they make the sounds because they did when they were younger. So now I'm asking her if she's okay, giving her a break. She said she's all right. She wants to keep going. Sometimes they surprise me when they do that. And I traditionally use a 150 for the upper arch and a 151 for the lower arch. And I have these extra tools out, but I don't open them unless we actually use them. So I couldn't get enough luxation force and width, so I went to the larger elevator. That extra millimeter of width can sometimes make all the difference in being able to rotate and lift up that tooth from down below.
Probably, but I don't want to be. I want to prove it.
She's telling me she's okay, but just wants it to be over. So.
Open up, Connie. Connie, can you open up?
And I actually did the upper arch before the lower, so you could see that she calmed down quite a bit by the time we got to the lower.
Oh, lots of pressure, lots of pressure. Great job, Katie. Oh, you were doing so good.
There's a lot of pressure when you start. I think she made a sound there when I hadn't touched her yet, from the actual movement of the teeth themselves. But I'm trying to get that 1 to 2 millimeters of mobility, of periodontal mobility, before I try to actually do anything. So she won't open big enough for me to get the normal sponge throat pack in. So I'm trying to get a piece of gauze spread in the back of her mouth so that if anything were to drop, then it should be fine.
Good job.
Is it back here? Is that what's bothering you? Okay.
So she's saying that the palate of her mouth, and I'll be honest with you, I typically don't numb that because I don't actually touch that palatal tissue at all. The only time that it might get touched is when the forceps itself might come down, but it doesn't go under the tissue. So I think sometimes, yeah, you can tell she just wants to feel it. And the phrase, when it's white, it's right, means that I'm going to put that in and blanch the tissue until it's white. So I know that the epinephrine is doing its job and I can see the extent of the anesthesia that I've given her at the time. And so whenever I have to do some additional anesthetic, I don't mind giving some extra just to give them some extra time of comfort. This is lidocaine, so we know we have about 45 minutes of pulpal anesthesia and maybe double that with the soft tissue. So for an extra hour, maybe she'll be comfortable, with the denture. And you can see I'm not gonna waste a lot of time. I'm gonna go to the other side while it's starting to work. When it's buffered like we have, it takes about 30 seconds for it to actually work. And you can tell, even though I just gave her the anesthetic, I think it was more of a placebo effect that she just wanted to feel it because it's only been a few seconds since we did it. And we're right back on the tooth that she just, said was bothering her so much. My little throat pack caught it. There. Perfectly comfortable in under 30 seconds with buffered anesthetic. You can look in there again, no flap. Okay, so I'm going to go back up. If there are any questions, I would like to take them now, or if I can help with anything else, or do whatever, let me know.
So thank you so much for the beautiful session. It was actually quite amazing and was, quite attracting to the audience for sure, especially me, moreover. Okay.
I can actually see how many people are watching the video. So can you tell me how many people were on watching it?
There were more than actually. I'll get back to you with that.
That's okay. You can let me know later. I thought maybe people would be able to type me a question while I was doing this, but I don't see any. But I'm happy to take them if they have any.
Yes, sir. We are having some questions with us. Okay. One is from Dr. Suraj. With so much implants in upper jaw, why to choose denture? If we can deliver bridge like PFM or zirconia, please elaborate the difference.
It's just cost. If the patient, the denture is of course much more affordable for the patient than it is to do the PMMA. So if you go to my website, let's see, I don't have my website on here, but it's smilesforsiouxland.com. Let's see, I don't know, or if I can, I'll get you my website, but if you go to my website, you can click on the cost of dental implants and it goes through each of the packages and what the cost is. So I think it's over $20,000 for the zirconium screw retained system. And then the most affordable is the dentures just attached with O-rings to the mini implants. So the screw retained are traditionally conventional implants. I do mostly conventional implants, but I also do some of the mini implants, but it's only cost. When the mini implants cost maybe $50 to $100 in our country. So that's much cheaper than maybe a Straumann implant, which would be $500 plus. And so we can give them 10 implants for the price of one Straumann conventional implant. So it's much cheaper for us to do that, which gives them much more strength. If one were to fail, the case would not fail, but the patient would still have a happy case. Whereas if I place one Straumann and the one implant failed, the case fails. So the prosthetic failure is the key. If the patient has the prosthetic in their mouth and they're happy, then we're happy.
Okay. So that's the reason behind using 10 mil implants in cases of, like, in replacement of all-on-4. So that's your reason behind that?
Well, the all-on-4, I've done those. And the reason for those is typically when you don't have sufficient bone and the sinuses are large and close to the front. With the mini implants, you could not use 4 implants and do a screw retained prosthetic like an all-on-4. Unfortunately, when you have an all-on-4, usually you have an all-on failure, because we now say all-on X, meaning that if you have one of those 4 implants fail, the whole prosthetic fails. So many practitioners will do 6 implants or 8 implants that are screw retained instead of all-on-4. And so with the mini implants, they're so affordable. If you can put in more and it makes the prosthetic tighter, and it also is affordable for you and the patient, and they have sufficient bone, and it allows you to transition to something in zirconium in the future. So maybe today they get the denture, next year they get the PMMA, the year after that they get the zirconium. They can just keep saving up and doing that. But at least it gives them an option that they wouldn't have if they went with an all-on-4 and lost 1 or 2 of the implants. I've done all-on-4 revisions for other doctors that I have not placed. Dr. Ramsey Amin, who was on prior, does a lot of case revisions for large, full arch reconstructions, and he could talk extensively about failures of all-on-4 cases.
Okay. Next question we have from our association itself. Do you not need flanges on the PMMA full arch?
No, absolutely not. In fact, you could grind that down even further than it was. The Trilor itself is incredibly strong. It's a carbon fiber. And in some cases, I've done Dentatis is a company in the United States that makes a screw retained narrow diameter implant. Dr. Ziv Mazer lectures extensively for them. And I've done screw retained dentures. And in those cases, I make an ovate intaglio surface. So with the PMMA, depending upon if I need it for cosmetics, I'll bring the flange up. But if I don't, I'll make it actually very narrow, because it's much easier to get cleaning supplies underneath it and to keep that nice. So it very much depends on the patient and the cosmetic concerns, but you could actually make the flange much, much shorter. It's the Trilor is just like zirconium in that it's very, very strong, and I've yet to have one fracture, and I've done a lot of them now.
Okay. So another questions are by me itself. So you're saying that Trilor, okay, my question is, what sort of material is Trilor? Is it a resin material, or like what sort of material it is?
No, it looks like pressed paper. It's a carbon fiber, and it costs it's a U-shaped wafer, and you can grind it with diamonds or burrs. It gets inlaid into the denture or material itself, and then we use either a resin cement or an acrylic to pick up the housings at that point to put them in there. But it costs about, I think I paid $110 for each U-shaped piece that would go inside the prosthetic. So you would have to calculate the cost of your denture or PMMA. With our lab, our PMMA pucks run anywhere from $25 to $250. And then you'd have the Trilor. So you could have $140 to maybe $350 in cost to you at the lab cost to do the procedure. And then if you had 10 mini implants at $500, you're under $1,000 for something that looks essentially like an all-on-4 and could potentially last as long as an all-on-4, which in my office I'm charging somewhere, I think it's between $20,000 and $25,000 for that. Whereas with the denture one, I'm charging, you know, around $5,000.
Okay. Oh, that's nice.
So yeah, if you go to the site, you can see the breakdown of what each stage of those progressions can be, because the patients get the options.
Okay. So I wanted to ask you that the local anesthesia you used in the video, the second video you shown us, the upper arch,
Mhm.
what was it exactly for the upper arch? You used local infiltration or it was intraligamentary? The local
Ah,
anesthesia used.
so it's 2% lidocaine with 7 units of 8.4% sodium bicarbonate. And then I do an infiltration everywhere on the upper arch. And then on
Okay.
the lower arch, I do the blocks for the molars, and I do infiltration everywhere else.
Okay. And like you've shown all the cases, I feel they are all mostly chronic generalized periodontitis, right?
The one where you saw I would say, actually, I'd say more of them are actually where you have chronic apical abscesses due to cavities, due to caries.
Okay.
In the case where you saw the pile of all the teeth, there was no periodontitis there at all. In most of the cases, there's not periodontitis. The woman who kept breaking her teeth over and over at the end, it was not periodontitis because you could tell the roots kept breaking. The bone was very, very firm. It's more that there's caries into those teeth to the point where they're financially not restorable for the patient. And they don't want to walk around with 3 teeth or 4 teeth anymore, and they don't like the fit of the partial, they won't wear it. So they want something else.
So the patients are not aware about like they're having abscesses for particular teeth. So don't they appear to you when they're having single abscess? Why are they appearing to you when they're having multiple abscesses?
Well, that's interesting. Sometimes it's due to finances. Sometimes what they'll do is they will borrow antibiotics from a friend when their abscess bothers them, and it'll make it go away for a while, and then they'll develop another one, and so they get these chronic, infections until what happens is that they've borrowed antibiotics from their friends so many times that the antibiotics no longer work for them. They're resistant, and then they finally start to swell up, and they go to the emergency room where they also get antibiotics, and then they're told to see a dentist. So sometimes they'll go to the emergency room 2 and 3 times before they actually come in because they know they don't have the money to take out the teeth, or it's their front tooth and they don't want to remove it because it will look bad without their front tooth. So I live in an area, there's only 800,000 people in the state, where I live, which is very rural. So we are very far apart. There might be no dentist for 100, let's say 200 kilometers. You might not have a dentist. So you might have to drive. I have patients that drive 6 hours, 8 hours to come see me at times. So there's no access to dental care because of where they live. And so sometimes for that reason, they might wait a long time as well. But I would say in general, it's due to finances. They don't have the money. As you know, dental care costs a lot of money in the United States, and we don't have a public healthcare system that covers dentistry. So we have some access to care if your income is low enough, but there's definitely a hole in the middle of people that can afford the care and people that can't afford the care. And that's the group in the middle that tends to struggle when they have these problems, and how often can they get the work done and what can they get done when they do come in for it.
Okay. So that's the problem with the population itself. Okay.
Yeah.
Initially, yes.
I do have a license in California, which is on the West Coast, and that's a very, very different population than here in South Dakota and Nebraska, where I'm also licensed. So it very much depends on where you practice. If it's a big city or a rural area, what you will see for cases. So 2 dentures a week for me is kind of normal, but my friends in California probably haven't done a denture in 5 years, 10 years. The dental IQ of the patients are very, very different, and their expectations are very, very different.
So you believe that the area where you were staying, people might be having they won't be having awareness about the dental problems. So you feel, is this the case with them?
I think it's not so much an awareness, it's more of a concern. We have a lot of farmers in the community, and many of them will have accidents on their farm and lose their fingers and their arms, or have large cuts, and they literally just get up and keep working. So they're used to having pain as something that's on a daily basis. So it's not as big a concern when someone lives with pain every day. And walking around with decay on your teeth or missing multiple teeth is much more common here than you would find in California. So it's considered normal. If it wasn't considered normal, I think more people, would take advantage. When you're missing a front tooth, that's not considered normal. And that's when they usually come in. You saw the woman in the video at the end, she had just these 6 teeth left and 2 of them were abscessed. And that's why she wanted to get them replaced finally, because when she smiled, you now saw big holes in the back. But it wasn't until her smile bothered her, And what happens is when they lose the back teeth, the front teeth get overused, and then through trauma, they get abscessed through overuse. And so that's why they'll have multiple teeth abscess at the same time. And they do feel it and they do know it, but they don't have the money to do anything. So they'll come in with swellings under their eyes and everything else.
Okay. And one more thing. So you take out all the teeth for the denture, and don't you believe in suturing the face and then putting the denture? Won't keeping them open and putting the denture would cause any sort of infection because the wound is all open?
No, I actually also work in a plastic surgery office sometimes. And it's very much about how the suturing goes. I do have some suturing videos, but we didn't have time with the length of the lecture today about those. But in fact, we actually want to remove, if I were to place sutures, we'd remove them at 3 days. And that's something that we don't hear a lot in dentistry. We put them in, and why do we remove them in 2 weeks? That's because that's when we want to see them on the schedule. Or I can tell you right now, I use a PDO, polydioxanone 4.0 suture almost exclusively for all surgery procedures. I have a 5.0 and a 6.0 that I use for periodontal surgery. It dissolves over about 62 days. So I never have the patient come back at all because they come out on their own and dissolve. And they also are wicking, so they do not allow bacteria to stay or touch them. So when they come back in, they're perfectly clean all the time. And it's very affordable compared to a Teflon suture, which you do have to remove later. But as far as the sutures go, the denture itself, they're going to wear it for the first 48 hours without taking it out. So there's nothing better than the denture to hold that tissue closed and tight. Now, you also must remember, I did not flap. So that tissue is very, very tight. You cannot get that tissue off that bone. So the only thing that's loose at all are the papillas at the top. And the papillas are going to get pushed down just because the denture is in place.
Okay. I'm getting that. Last question from myself. You're using a rotor in the initiation, right?
Oh, what was that? I'm using what?
Air rotors?
You talking about the handpiece, dental handpiece?
Yeah, the handpiece. What is exactly purpose? What's the exact purpose of that using? Are you breaking the contact areas or the interdental area?
Yes. So what I'm doing is removing the interseptal bone down to the spot where I'm at the center of resistance. That piece of bone, and I talked about that briefly in the lecture, is the part that will break off and come out of the tissue over time that will bother the patient. So it inhibits the tissue from fully closing. And it also stops the elevator from being able to go apical enough for me to elevate it at the center of resistance. And so, yeah, we call that a dental handpiece, and that's electric. So it's not putting any air out. It's just using some water.
Okay. Yes, sir.
If you're going to the IAO meeting, I will see you there and you can ask me about it in person.
Definitely, sir. I would love to actually, because I was attending the lecture for half of the part, and I was, piled up a lot of questions for you. So thank you so much, sir.
Well, you're very welcome.
Yes, sir. Thank you for sharing the knowledge with us and the beautiful cases you've shown us. It was quite tremendously awesome. So thank you, sir. Thank you for the queries solving also, and for the knowledge you shared.
All right. Thank you very much. I appreciate it.
So with this, I would address the participants to follow up for the future sessions and more of the amazing lectures to be piled up and lined again. So you can all follow up to www.geomech.org for the speaker schedules, participation certificates, as well as C certificates. So thank you so much for the session.
All right, thank you. Appreciate the opportunity.
Thank you, sir. So with this, we'll move on to the end of the session. Thank you.